Good day everyone. Today we will be discussing an extremely important topic in healthcare, pharmacovigilance. Pharmacovigilance plays a critical role in ensuring drug safety, protecting patients from harm, and improving therapeutic outcomes. To understand this field, we must first define what we are trying to prevent or manage: the adverse drug reaction. The WHO defines an adverse drug reaction as any response to a drug which is noxious and unintended and which occurs at doses normally used in man for prophylaxis, diagnosis, or therapy of disease or for the modification of physiological function. Thus, this definition excludes overdose, that is accidental or intentional, drug abuse, treatment failure, and drug administration errors. Often the term adverse drug reactions and adverse drug event are used synonymously, although they are not. An adverse drug event is a broader term which includes any untoward medical occurrence presenting during the administration of a drug. Thus, an ADR can also be considered as an ADE, but not all ADEs are ADRs. And ADE does not necessarily have a causal relationship with the drug, but ADR which has harm directly caused by the drug itself. And there is a third term, that is medication error. It is the inappropriate use of a drug which may or may not cause harm. Let us differentiate the key terms ADR, ADE and medication error. ADR which causes direct harm. ADE and AD adverse event during the treatment may not be caused by the drug, and medication error is a mistake in prescribing or administering. For example, medication error. When a doctor prescribes a patient with injection pantoprazole 40 mg IV OD, giving wrong dose, that is injection pantoprazole 20 mg IV OD, is a medication error. Second scenario, when the patient is prescribed with injection pantoprazole 40 mg IV OD, and after the administration of first dose injection pantoprazole, that 40 mg, when the patient develops an allergic reactions, any kind of rash, breathlessness, any kinds of reactions to the drug, then that is called as adverse drug reaction. Now, what is the concept of causality, or what does this causal relationship mean? A causal relationship exists when a drug is thought to have directly caused or contributed to the occurrence of an ADR. Establishing this link is the core challenge of pharmacovigilance. This is not always straightforward. It requires clinical judgment, evidence, and timing correlation. This leads us for better causality assessment of ADR. There are certain predisposing factors that which makes patients more prone to ADR. Why do some patients react while others don't? There are several variables. What are those different variables? First one, demographics. Women generally report more ADRs than men. Also, age is also a major factor. Another factor is the clinical picture of the patient, polypharmacy. If the patient is taking multiple drugs, there are chances of drug interaction which can predispose to the occurrence of an ADR. So, taking multiple drugs, that is polypharmacy, significantly increases the risk of developing an ADR. Next thing is biological makeup, race, genetic factors. All these factors play a great role in drug metabolism that itself can cause occurrence of ADR. For example, elderly patients are having more ADRs. Why? Because they are taking multiple drugs. That is one cause, that is polypharmacy. Second reason, they have changes in their biological activities, like they have reduced metabolism, they have multiple comorbid condition, that all predisposes the patient to the occurrence of an ADR. Now we go to the classification of an ADR. There are different types of classification, and there are different bases by which the ADR is classified. First one, based on the onset of event, the ADR is classified into acute, subacute, and latent. What is the difference? If the reaction occurs in less than 1 hour, they are called acute event. acute ADR. If the event occurs within 1 to 24 hours, they are called subacute ADRs. And if the reaction takes more than 2 days to manifest, they are called latent ADRs. Now, next classification is depending on the severity. First one, minor ADR. There is no therapy or hospitalization change needed for this kinds of ADR. Second type is moderate ADR, that requires a change in therapy or specific treatment, but that doesn't require stopping of the drug. The specific treatment or whatever the drug was started, that can be continued. Next type is severe ADR, that is life threatening or that may cause permanent damage and require intensive medical treatment. And the lethal ADR, which causes direct or indirectly contribute to the death of the patient. And what is this seriousness as defined by FDA? FDA defines serious criteria as those which results in the death of the patient or which may cause life-threatening conditions which require patient's hospitalization, or if the patient is already hospitalized, those causes prolongation of hospitalization or cause disability, congenital anomalies, and which requires any kind of intervention to prevent permanent injury. Next classification is classification based on the incidence or occurrence of the disorders. First one classified as very common, that is incident in 1 in 10. Second one common, which has an incidence rate of 1 in 100. And uncommon ADRs are which having incidence 1 in 1000. Rare ADRs which have an incidence of 1 in 10,000, and very rare which have incidence as 1 in 1 lakh. Examples of each one with relative to carbamazepine include: for very common ADR, carbamazepine induced drowsiness; common ADR, carbamazepine induced fluid retention; uncommon ADR of carbamazepine is diarrhea; one rare ADR of carbamazepine is depression; and very rare ADR is arrhythmia with carbamazepine. And the other classification is Rowling-Thompson classification and is the most widely recognized clinical framework. That includes type A to F classifications of ADR. Now we will go in detail about each classification. Type A ADRs are also called augmented ADRs. These are dose related, predictable and common. They are an exaggeration of the drug's normal action, such as bleeding from anticoagulants or hypoglycemia from insulin. They can often be managed by reducing the dose. Common example, bleeding from anticoagulants like warfarin, hypoglycemia from anti-hyperglycemic drugs, that is insulin. Type A is further classified as, first one, it is the extension of primary effect, that is augmentation of therapeutic effect. The example is hypoglycemia with insulin or hypotension with beta blockers. Second type is secondary effect, that is the pharmacological adverse event. Pharmacological effect is not the direct action of the drug, that is a secondary effect of the drug. Example is diarrhea with the use of antibiotics. Antibiotics are not used for the treatment of diarrhea, or antibiotics doesn't directly cause diarrhea. Antibiotics cause diarrhea by decreasing the growth of or destructing the microorganisms in GI flora. That destruction indirectly causes diarrhea. So that kind of reaction also comes under secondary effect of augmented type adverse drug reactions. Next type is bizarre type adverse reactions. Type B reactions of ADR are called as bizarre type reactions. These are unpredictable, rare and not dose dependent and comparatively very less common. They are not easily reversible, and these reactions are mostly host dependent factors are also coming into play in type B reactions. Example are anaphylaxis by penicillin, skin rashes which are caused by antibiotics. Type B classifications are further classified into four. First one is drug intolerance, lower threshold to normal pharmacological action of drug. The drug which is when is given in normal doses, some patients gets lower threshold and thereby precipitate ADR. An example is tinnitus with a single average dose of aspirin. Second type of type B reaction is hypersensitivity reactions or immunologically mediated reactions. These kinds of reactions are immune mediated response to a drug in a sensitized patients. Example is anaphylaxis with penicillin. Next kind of classification in type B reaction are pseudo-allergic reactions which occurs due to direct mast cell activation and degranulation by specific drugs. The drugs which are causing pseudo-allergic type B reactions are opiates, vancomycin and radiocontrast media. And the last type of type B reaction are idiosyncratic reactions, which is an uncommon and abnormal response to a specific drug, and that occurs usually due to genetic abnormality, that is due to drug metabolism changes or alteration in receptor sensitivity. These reactions are usually can become harmful, even fatal, and occurs in very low doses of the drug. Examples include anemia by antioxidants in G6PD deficiency, paralysis due to succinylcholine. The other classification or next type of Rowland-Thomson classification is type C reactions. These are type C reactions are chronic reactions which are associated with long-term use of the drug. Example include NSAID-induced kidney injury, corticosteroids-induced cataract, steroids-induced osteoporosis, etc. Next classification is type D reactions. These are also called as delayed reactions. These reactions becomes evident sometime after the use of a medicines. Example include leukopenia, which can occur up to 6 weeks after the dose of lomustine. So due to the timing of ADR occurring, they are difficult to detect. So these ADRs are difficult to detect and difficult to classify. Next kind of reaction is type E reactions. This reaction occurs when the drug use is ended, or these are also called as withdrawal reactions. Example are seizures and phenytoin withdrawal, adrenocortical insufficiency in steroid is withdrawn. And type F is the next category, that is also called as unexpected failure of therapy, and this occurs usually due to drug interactions. When two antagonized effect drugs are given together, they can cause type F kind of adverse drug reactions. And mostly type F reactions are precipitated due to drug interactions. Example is St. John's wort and herb, which reduces the efficacy of hormonal contraceptive. Another example is spinach or vitamin K high content foods, which reduce the efficacy of warfarin. Last class is type G reactions. These are genetic reactions and are very rare. This causes irreversible genetic damage. For example, carcinogens, genotoxins, teratogens. Carcinogens are drugs which can cause secondary tumors or cancers. Genotoxins are drugs which causes direct toxicity to gene and thereby results in gene mutation. And teratogens are drugs which can cause abnormality or some kind of mutation or changes in babies, fetus, when the drug is being administered to pregnant mothers. So those drugs which causes toxicity to fetus, they are called as teratogens. Carcinogens and genotoxins examples are mostly anti-cancer drugs. Alkylating agents are examples of carcinogens and genotoxins. Teratogens example isotretinoin. Other classification scheme include DOTS, which takes into consideration dose, time and susceptibility. First factor which is being considered is dose. ADRs can occur at low doses, normal doses and high doses. So this DOTS classification classify ADR according to the dose of the drug, the time of event and the susceptibility of the patient. The first factor we are being considering is dose or the response to the drug. First one, if the ADR can occur at doses below the therapeutic doses. Example is anaphylaxis with penicillins. Mostly anaphylaxis with penicillin. Those patients who are susceptible to penicillin or those who are allergic to penicillin produce an adverse drug reaction even in test dose. Test dose is very low doses of a drug is only being administered, that too intradermally. IV administration is also not done. So those patients who are already sensitive or allergic to penicillin may produce adverse drug reaction in low doses, in low therapeutic dose. Next kind of reaction is adverse drug reaction occurring in normal therapeutic dose range. Example include nausea with morphine. Third kind is at high dose, adverse drug reaction occurring at high doses. Example, liver failure with paracetamol. Next is time course, where the drug reaction is precipitated even during the first dose or to subsequent doses or after a long duration, after multiple doses of the drug. This can also be a basis of classification in DOTS classification of adverse drug reaction. First time course, ADR with the first dose. Example is anaphylaxis with penicillin. After a time or with long-term treatment, adverse drug reactions. In first few days, ADR of nitrate induced headache is an example. For 10 days to 10 weeks, toxic epidermal necrosis with sulfonamide class of drugs. These ADRs are not precipitated in first dose, they are precipitated after subsequent doses or after 4 weeks to 10 weeks. In that gap only these kinds of ADRs are precipitated. The other classification in time course is on stopping the treatment, that is withdrawal reactions. Example include withdrawal syndrome of paroxetine, clear cell cancer with stilbestrol. On withdrawing stilbestrol, patients experience clear cell cancer. Another example is steroid withdrawal syndromes, adrenal insufficiency in steroid withdrawal. Next class is susceptibility of patients. Susceptibility of patients can be defined according to patient factors that include genetics, age, sex, physiological state, other administration of other drugs or foods, disease conditions. Example of genetics, hemolysis which occurs with chloroquine in G6PD deficiency patient. Next one, age. In patients who are aged, prochlorperazine therapy can induce Parkinsonism. Third factor is sex. Age-induced cough in women is more pronounced than males. Physiological state, phenytoin in pregnancy can cause teratogenicity for fetus. Exogenous drugs or foods, warfarin, cranberry juice. Administration of warfarin and cranberry juice simultaneously can increase INR. And some disease states, those who are already have renal failure, those patients when being treated with gentamicin, these patients can precipitate deafness and renal toxicity. These are the classifications of ADR. Next we will see the processes in pharmacovigilance. Pharmacovigilance process is a cycle which involves collecting data, assessing the causality, coding it into databases, computing the risk-benefit ratios, and communicating findings for safe use. Why the detection of an ADR is important. Detecting an ADR is crucial and important in the management of any patient. Always suspect a drug as cause of symptom in a patient. Now, what are the factors which helps us in identifying an ADR? What are the factors that need to be considered, that need to be kept in mind while treating a patient or while viewing a patient for the occurrence of an ADR? Before the starting of therapy, identify the high risk drugs. High risk drugs are those drugs which have more potential to cause an ADR, which have more potential drug interactions. High risk drugs include antibiotics, anti-inflammatory drugs, anticonvulsants, etc. The greater the number of medications, the greater the risk of developing an ADR. At the same time, before the therapy, we need to identify the high risk drug, we need to identify the high risk patients also. Those patients which are categorized in high risk include those patients which have contraindications. If we are starting a specific drug treatment, those patients which have specific contraindication to those specific drugs, those patients are categorized in high risk. And if those contraindications exist, we need to check for the baseline parameters in those patients and adjust the dose accordingly. And we need to identify and prevent drug interactions. Identify the other patients which have previous ADR history and identify those patients which are on multiple medications. And the other category of high risk patients include pediatric patients. Generally, pediatrics and adults have no greater or lower risk in case of ADRs, but in some cases, in some patients, for those patients whose ADME properties are not fully developed, or there are variations in ADME that can cause occurrence of an ADR. Example is occurrence of grey baby syndrome in neonates when started with chloramphenicol. And elderly people are at higher risk of developing an ADR because those patients are more prone to have polypharmacy, multiple disease states, and changes in ADME, drug ADME, due to the change in or due to the advancing age. So most elderly patients, those patients who are being admitted in a hospital or those who seek hospital admissions, first cause which need to be kept in mind is always drugs. And other than polypharmacy, ADME changes or disease states, we need to also consider the conditions such as malnutrition or dehydrations, which can exacerbate the occurrence of an ADR. Some genetic factors also act as risk factors in occurrence of an ADR, that is HLA-B1502, which can cause SGS and 10 in Han Chinese but not in Caucasians. Causative drugs include carbamazepine and phenytoin. In HLA-B5701, abacavir can cause hypersensitivity syndrome, that is in Caucasians but not in Hispanics or Africans. HLA-B5801, in which allopurinol can cause SGS and 10 in Han Chinese, Europeans and Japanese, and not in other factors. Now, what are the other contributors to drug reactions? Some drugs, some diseases, and some infection can also cause adverse drug reaction. Examples include infections. Human herpes virus 6 can cause hypersensitivity syndrome reaction. Epstein-Barr virus can cause ampicillin hypersensitivity, and HIV infection can cause sulfamethoxazole hypersensitivity. Now, coming to the drugs, patients with history of any type of allergic reactions after the receipt of sulfonamides or penicillins may be at increased risk of reactions to other drugs. Also, in cephalosporin class, cross-reactivity also occurs in patients for multiple generations of cephalosporins, though not to all patients. Some patients are more prone to cross-reactivity, some patients doesn't not. Sometimes some psychological effects also come into play in adverse drug reactions. Example, nocebo effect, that is onset of reaction following administration of inert substance. In a study, there were 27 patients who reported adverse drug reactions to placebo. That responses of the psychological response or psychological ADAs are usually subjective, that is different from patient to patient. Examples of psychological ADAs include nausea, pruritus, and headache. These are influenced by factors such as patient's expectations, patient's previous experience, the study setting, etc. Then what are the factors that are helpful in detecting an ADR? We can detect an ADR by direct patient interview, identifying or obtaining patient's previous medical history, reviewing the case sheets or prescriptions containing drugs which include antihistamines or corticosteroids, checking for abrupt cessation of any medications, introduction of a new drug, changes in the brand name of the drug, when there is a change in lab values which is being noted in reviewing the case sheet, or the patients which develop new symptoms other than the symptoms which the patient was presented during admission. If there is an occurrence of new symptom, that can also be suspected as ADR. What are the factors that needs to be collected? Firstly, find out whether the patient is taking a medicinal product, and if the patient is taking the medicinal product, obtain the complete details of the patient pertaining to both event and medications, and if any treatment is given regarding that also, and all other relevant information regarding the drug administration and the treatment all need to be collected. What are the details pertaining to the reaction that needs to be collected? The nature and severity of the suspected reaction, time and onset of suspected reactions, duration of the suspected reaction, and previous report on reported reaction. Now, the details pertaining to the suspected drug, name of the suspected drug, the time of administration, complete and specific dosage regimen, previous report on the suspected drug. Other relevant information that also need to be collected include the demographic data of the patient, the presenting complaints of the patient, past medical and medication history of the patient, current drug therapy details including all the over-the-counter medications, treatment, whatever treatment is given with any other system of medicines like homeopathy, Ayurvedic, all those treatment modalities also to be included, and other specific risk factors. Then how do we assess this ADR? We need to correlate the collected information with the event. We need to consider the temporal time relationship between the administration of the suspected drug and the reaction, background frequency of the event, possible involvement of other causes, previous exposures, allergy, outcome of the reaction upon de-challenge and re-challenge. What should raise your suspicion? When should we suspect the occurrence of an ADR? Timing with the drug treatment. If there is a temporal relationship between the starting of the drug and the occurrence of the reaction, that should raise our suspicion. Abnormal clinical measurement while on drug therapy. Abnormal laboratory results while on drug therapy. New therapy started which could be used to treat the adverse drug reaction. Any specific patient risk factors, patients on concerns, the relationship between the event and the drug, assessing the strength of the relationship between the drug and the event. All these factors can increase our suspicion about the drug. Now coming to the causality and TRIP factors. TRIP factors include time, recovery, independent evidence, and predictability. When an ADR is suspected or an ADR is identified, we need to do a causality assessment, and the causality assessment is made by considering the following criteria, which include previous experience with the drug, are there any alternative etiologies, timing of the event, the drug levels, if there is occurrence of overdose, re-challenge and de-challenge. The time from starting of the drug to the appearance of symptoms of ADR, and independent evidence for this include de-challenge, re-challenge and blood level measurements of the drug. What is de-challenge? De-challenging is assessing the resolution of ADR on withdrawal of the drug, whether the ADR abates or decreases. Re-challenge is assessing reappearance of the ADR on reception of the drug. Medicine is stopped and after ADR is abated, medicine is re-administered to elicit the response, and it is not clinically practically possible. Now we will see about the causality assessment methods. Most commonly used method include WHO scale and Naranjo scales. Other methods for causality assessment include European ABO system, Karch and Lasagna scale, Yale algorithm, Kramer scale. Why are these different scales used, and what are the advantages and disadvantages? These scales doesn't have a common platform for validating, or they are not commonly validated. So each causality can be varying with what are the scales used or what are the methods adopted. A worldwide procedure is not yet established. So these data are determined by the documentation of case report and the occurrence of evidence. How does this? We'll see in detail about WHO scale. WHO scale classify ADRs into different categories including certain, probable, possible, unlikely, conditional or unclassified, unaccessible or unclassifiable. First criteria or first causality is certain. If an ADR fills the following criteria, that ADR is called as certain ADR. What are the criteria that need to be met? First one is event with a plausible time relationship to the drug intake. No other explanation like diseases or other drugs which can cause this reaction. The event is definitive. There is a specific problem or specific ADR that can be identified. Response to withdrawal is also plausible, and there is a positive re-challenge. The key factor of certain causality in WHO scale is positive re-challenge. Next causality in WHO scale is probable. An ADR is said to be probable according to WHO scale when there is an event with plausible time relationship and there is no other explanation like diseases or drugs, and response to withdrawal is plausible. No re-challenge. Re-challenge is not done or the result is unknown, but the key feature is positive de-challenge. Positive de-challenge means once the drug is removed from the system, from the body, the ADR is completely abated. That is the key feature of probable scale in causality assessment in WHO. Next causality is possible. Event is said to be possible in WHO assessment scale when the event with the plausible time relationship that could also be explained by diseases or other drugs. There are other chances of there can be other causes of reactions like other disease or other drugs. Information on drug withdrawal is lacking or it is unclear. The key feature for possible causality is other explanation for the event are also possible. Next causality is unlikely. Event with a duration to onset that makes a relationship improbable. Diseases or other drugs provide plausible explanations. Event does not improve after de-challenge. The key feature of unlikely causality is several factors indicate strongly that the event is not a reaction. Next causality is conditional or unclassified. An adverse event has occurred but there is insufficient data for adequate assessment and additional data is awaited or under examination. Key feature for conditional or unclassified are cannot assess with the available information. Next causality is unaccessible or unclassifiable. There is a report with an event which cannot be judged because of insufficient or contradictory informations. report cannot be supplemented or verified. The key feature is data elements concerning the events are inadequate and will not be available. This is WHO scale. Next kind of categorization is Naranjo scale. Naranjo scale classifies ADR into 4 different categories, that is definite, probable, possible, unlikely. Naranjo scale uses a questionnaire where we need to answer each question regarding the event and we put marks according to the answer of those questions. According to the mark, we sum up the marks and we then classify the ADR into definite, probable, possible and unlikely. If the sum goes up to 9 or greater than 9, that ADR is called as definite ADR, and the answer for questionnaire comes between 5 and 8, they are called as probable ADR, and the answer comes around 1 to 4, they are called possible ADR, and if the answer is less than 0 or less than or equal to 0, they are unlikely ADR. What are the questions that need to be answered in Naranjo scale? First question: are there previous conclusive reports on this reaction? If the answer is yes, we put +1 mark. If there is no, answer is no, we put 0, and if we don't know the answer, we put 0. Second question: if the adverse event, did the adverse event appear after the suspected drug was administered? If the answer is yes, we give 2 marks. If the answer is no, we give -1 mark, and if we don't know the answer, we put 0. We doesn't give any marks. Third question: did the adverse drug reaction improve when the drug was discontinued or a specific antagonist was administered? If the answer is yes, we give 1 mark. If the answer is no, and if the answer is, if we don't know the answer also, we both for no, and if we don't know, we give 0 marks. Fourth question: did the adverse drug reaction reappear when the drug was re-administered? If yes, we give +2 marks. If no, we give -1 mark, and if we do not know the answer, we put 0. Next question: are there alternative causes that are other than the drug that could on their own have caused the reaction? If the answer is yes, we put -1 mark. If the answer is no, we put +2 mark, and if we don't know the answer, we put 0 marks. Next question: did the reaction reappear when a placebo was given? If the answer is yes, we give a -1 mark. If the answer is no, we give +1 mark, and if we do not know the answer, we put 0. Next question: was the drug detected in the blood or other fluids in concentration known to be toxic? Then if the answer is yes, we give +1 mark. If the answer is no, we put 0 marks, and if we do not know the answer, we put 0, or if we doesn't check the blood value also, we put 0 marks. Next question: was the reaction more severe when the dose was increased or less severe when the dose was decreased? If the answer is yes, we give 1 marks. If the answer is no, and if we doesn't know the answer also, we give 0 marks. Next question: did the patient have a similar reaction to the same or similar drugs in any previous exposure? If answer is yes, +1. If the answer is no, or if he doesn't know the answer, we give 0 marks. And the last question: was the adverse event confirmed by any objective evidence? For objective evidence, we specifically look for any specific lab values pertaining to the reaction. If the answer is yes, there also we give +1 mark, and if the answer is no, and if we doesn't know the answer also, we give 0 marks, and we sum up the total score, and according to the sum, we classify the ADR into definite, probable, possible or unlikely. Now we will see some examples of different types of ADRs. Definitely related ADRs example include dizziness 45 minutes after ingestion of an oral antihypertensive drug with no concomitant drugs. Adverse event stops on stopping drug and restarts when taken again. Injection site reaction 30 seconds after a subcutaneous injection of drug. Next example is event known to be commonly caused by drugs such as anaphylaxis, 10 SJS, granulocytosis, radiodyskinesia, pseudomembranous colitis, aplastic anemia, all these areas come under definitely related areas. Probably related areas include thrombocytopenia after taking an oncology drug, diarrhea after an ampicillin, vaginal candidiasis after an antibiotic for bronchitis. Examples for possibly related areas include abnormal liver function test after taking an antihistamine, headache. And unlikely related areas include cancer of the colon diagnosed after 3 doses of an antibiotic, or myocardial infarction 3 weeks after taking a drug that has a terminal half-life of 10 minutes, etc. Now we will see the disadvantages and advantages of the algorithms which are being used. The advantages of algorithms include decreases the disagreement between the assessors, classify the relationship likelihood of the reaction, marks individual case reports, and improve the scientific basis of assessment. What are the problems in assessing the causality? The causality assessment is often highly subjective based upon clinician's judgment. If two different branches of clinicians are filling the causality assessment scale, we get different scores. So whoever is filling the causality assessment scale, the answer or the value depends upon those subjects' clinical judgment. And ADR frequently mimic other diseases that always comes as a barrier in marking the questionnaire or assessing the causality. Eliminating the alternative causes of suspected reaction is a bigger challenge in causality assessment. Many of the symptoms attributed to ADR occur in healthy individuals who are not taking any medications. Accurate quantitative measurements of likelihood relationship is not possible. It fails in distinguishing valid from invalid cases, as all ADRs can be reported, cannot prove the connection between a drug and an event, fails in quantifying the contribution of a drug to the development of an adverse event, and it cannot change the uncertainty to certainty. Now, how can we manage the ADR? Always the management of ADR requires rapid actions. First and foremost step in managing an ADR is withdrawal of suspected drug. If the reaction is likely to be dose related, dose reduction can also be considered. The decision on treatment of suspected ADR can be done by considering the following factors such as seriousness or severity of the ADR, seriousness of the disease, benefit or harm assessment. If the reaction is serious, withdraw the suspected drug and treat the patient urgently. If the disease is serious, consider the effect of not having treatment. That means we are going to look for the risk-benefit ratio. Continue the treatment and treat the symptoms of the reaction if necessary. Also, if possible, consider an alternative drug and try to stop all the unnecessary drugs which were already started or which are being on treatment. If the reaction is mild, continue the treatment if necessary. Stop any unnecessary drugs. Consider dose reduction if that also does the job. Reassure the patient, and if warranted, start any symptomatic treatment. What are the factors that need to be considered while managing an ADR? Always have a clear therapeutic objective in mind. That means after doing a risk-benefit ratio assessment, what are the risks and what are the benefits? We need to assess them carefully, and we need to keep what are our therapeutic objectives strictly in mind. Do not treat the patient longer than necessary. Always review the patient regularly, and always look for the simpler ways to manage the ADR. And what are the management options? First one, continue the medications. If modification is required or needed, modify the treatment. Continue the medication if it is medically necessary, if there is no reasonable alternative and the problem is mild and it can be resolved over time. Discontinue non-essential medications. Administer appropriate treatment such as dextrose in hypoglycemia, antihistamine in case of rashes or allergies or itching, epinephrine if there is a hypertension, naloxone in cases, corticosteroids and glucagon in their respective cases. Provide supportive or palliative care such as hydration, analgesics, antipruritics or local supplements. Consider re-challenge or desensitization and provide specific information to the patient. What is desensitization? Desensitization is administration of a drug to a person in whom drug allergy has been established but requires drug and no other substitute is available. So in desensitization, we administer small doses to remove or reduce the antibody which are producing the drug reaction. What are the benefits of desensitization? They are relatively safe, which have established protocols for many drugs, and that allows for re-administration of medication. That also comes with some disadvantages, including these are temporary effect that doesn't determine if the patient is allergic or non-allergic to drug, and we need to repeat this process for every subsequent courses of the same drug, and this cannot be done in every drug. Now coming to the reporting of an ADR. To report an ADR, you need not be certain, just be suspicious. Make sure that sufficient or adequate information is available, and the most commonly adopted method for ADR reporting is spontaneous reporting. Who can report an ADR? Reports can be completed by doctors, dentists, pharmacists, nurses, consumers. Any healthcare professionals can report an ADR. What should be the minimum information while reporting an ADR? There should be patient identity, description of reaction, exposure of the drug or the suspected drug, temporal time relationship between the exposure and the reaction, pre-challenge status and de-challenge status if available, fate of the suspected drug, treatment given, outcome of the reaction, any other possible causes, and the reporter's identity is also important. And what are the type of ADR that needs to be reported? Any reactions of any type, serious reactions that include life-threatening reactions, fatal reactions, reactions resulted in disabilities, permanent harm or congenital anomalies, severe reactions of any type, any reactions to newer drugs, reactions which resulted in increased healthcare cost, newer reactions to any drugs in the market, rare and uncommon adverse drug reactions. How can we report? We can report ADRs through reporting forms, and also can be reported directly to WHO database through Vigiflow, that through IMC centers, IMC's ADR monitoring centers. Using an ADR form, we need to fill certain criteria, or we need to fill up the blank spaces in the ADR form. What are the data that need to be included? Patient demographics, prescriber details, suspected drug or drugs, data suspected drug started and stopped, date of ADR occurrence, brief description of the reaction, name and address of the reporter with the date of reporting. The mandatory fields in the ADR forms include patient initials, age of onset of reaction, reaction terms, date of onset of reaction, suspected medications, and reporter information. This is an example of suspected adverse drug reaction reporting form which is followed by PVPI in India, which include patient information, suspected adverse reactions, relevant investigations, relevant medication history, seriousness of the reaction, outcomes, suspected medications which include the name, manufacturer, batch number, expiry, dose, route, frequency, therapy start and stop date, and the indication for which the therapy is being started, action after the reaction like drug withdrawn, dose increased, dose reduced, does not changed, not applicable, etc., reaction reappeared after the reintroduction of the suspected drug, that is re-challenge. Also, they look for the concomitant medicinal products including self-medications and herbal remedies with the therapy dates with specific indication. With the report, also it requires reported details and any other additional informations if available. Now we will see the steps in ADR monitoring. First one, identifying the ADR, assessing the causality, documenting the ADR, reporting the serious ADRs to PV centers or ADR regulatory authorities. So most common method of ADR reporting is spontaneous reporting. So what is spontaneous reporting? Spontaneous reporting is an unsolicited communication by healthcare professional or consumers that describes adverse drug reactions occurring in a patient who was given one or more medicinal products that does not derive from a study or many organized data collection scheme, or it is also called a clinical observation that originates outside a formal study. Those reports are called as spontaneous report. What are the things that needs to be reported in spontaneous reporting? If the system is a developing pharmacovigilance system, there we need to report all suspected ADR, encourage ADR reporting culture, build pharmacovigilance capacity, and develop a ADR profile of locally used medicines. If there is a doubt, report, and if there is something that concerns you, we need to report. If the pharmacovigilance system is already established, we may restrict what needs to be reported. For example, we can report ADRs to new medicines or ADRs in children or serious suspected ADRs. The same way, if there is a doubt or something that concerns you, we need to report. What are the pros and cons of spontaneous reporting? The pros covers the whole population, includes all medicines, detects new, rare and serious adverse drug reactions. They are easy to establish and inexpensive and less labor intensive. Cons include underreporting, that means it captures only suspected ADRs. There are chances of reporting bias. The denominator is unknown. In which population is being studied, we do not know. And difficult to detect delayed ADRs. ADRs with high background incidence are also difficult to identify. What happens to the submitted information? Information provided in this form is handled in confidence. The causality assessment is carried out at each IMCs by using WHO-UMC scale. The analyzed forms are forwarded to the National Coordinating Center through the ADR database. Finally, the data is analyzed and forwarded to the Global Pharmacovigilance Database managed by WHO-UMC in Sweden. The reports are periodically reviewed by the National Coordinating Center. The information generated on the basis of these reports helps in continuous assessment of risk-benefit ratio of medicines. The information is submitted to the steering committee of PVPI constituted by the Ministry of Health and Family Welfare. This committee is entrusted with the responsibility to review the data and suggest any interventions that may be required. Now, what are the role of pharmacist in reporting the ADR or identifying the ADR? Monitor the patients who are at greater risk of developing ADR. Monitor the patients who are prescribed with drugs highly susceptible to cause ADR. Assess the document the patient's previous allergic status. Assess the patient's drug therapy for its appropriateness. Create awareness about ADRs among patients, healthcare professionals and public. Assist healthcare professionals in detection and assessment of ADR. Educate and encourage the healthcare professionals and patients reporting of an ADR. Document the reported ADR in patient's medical record. Communicate the reported ADRs to appropriate concerned persons. Present the reports in meetings and conferences. Conduct workshops and seminars on ADRs for healthcare professionals. Disseminate the signals generated through publication of reports in bulletins or journals. So this is the flowchart of ADR detection. We need to detect the ADR, we need to assess the causality, and then it leads to the reporting of ADR. So Adverse drug reactions are a significant cause of morbidity and mortality. They may mimic the disease and should therefore be considered during differential prognosis. They account for approximately 5% of all hospital admissions and occur in 10 to 20% of hospitalized patients. They increase healthcare cost and adversely affect the patient's quality of life. Multiple drug therapy, age, and concurrent diseases are important general predisposing factors for adverse drug reactions, and about 50% of drug-related problems in healthcare are estimated to be avoidable. Pharmacists can play a vital role in detection, prevention, and management of ADR. To conclude, pharmacovigilance is essential for patient safety, rational drug use, and the improvement of public health. As a future healthcare professionals, your responsibility is to detect, assess, and report. Remember, every ADR reported can save a life. Thank you.